ECIPA is an amazing platform, and obviously we're glad to finally participate in an ECIPA event. Secondly, Dr. Limba, thank you so much for taking the time. We know time is of essence. We try to arrange it in a short amount of time, so thank you very much. And then to all the doctors participating, we're living in unprecedented times. So thank you so much to everybody participating in the event. It's really much appreciated.
Are you done, Johan?
So I would like to, can I quickly share a screen, Dr. Gqeberha? I just wanted to mention one of our new launches. So Glenmark Pharmaceuticals actually has a first-to-market launch.
Before you go, Johan,
yeah.
Dr. Limba, could you stop sharing? Okay, over to you, Johan. Thank you, Dr.
Perfect.
Limba.
So yeah, as mentioned, Glenmark Pharmaceuticals is actually launching a first-to-market generic in the Emollient category. It's called Glentress, which is a Scheduled 4. It's a 5% cream. So the indications that Glenmark is going to focus on with Glentress would be on superficial basal cell carcinoma in your adult patients, external genital and perineal warts in your adult patients. Thirdly, your actinic keratosis on the face, scalp in adult patients. As mentioned, it is a Scheduled 4. We will only be launching the sachets and not the pump. So it is 12.5 milligram of imiquimod. The dosage, there's 12 sachets as mentioned, and 250 milligram per sachet, which is a single use. The ACP that's been approved today from regulatory is 780 Rand and 86 cents ex-VAT. Obviously, we're going to focus on our dermatologists, general practitioners, as well as pharmacies. And then obviously, we're going to drive it with medical promotions, pharmacy substitutions, and then wholesale distributions. Just some key factors. We've got bioequivalence to the originator, and it is 23.8% more affordable than the originator. Then I would just like to quickly breeze through the rest of our dermatology portfolio. I'm not going to go into too much detail, but obviously everybody would know Saparaban ointment, which is another one of Glenmark's strong products on the market. Herceptin, which is your antibiotic and antimicrobial nasal preparation, and it's a treatment for the prevention of staphylococci infections of the nose. Our Sinelar range, which is a topical corticosteroid treatment to provide symptomatic relief of dermatosis. And I think the crucial part here is that it's in 3 different formulations. It's in a cream, ointment, and a gel formulation. Just important to note, the plain fluocinolone acetonide is the only one in a gel formulation. Range of antifungal cream, Gqeberha, which is our miconazole nitrate 2% with Emsloid technology. Emsloid technology is just to help with penetration and to maintain a healthy skin. The Riva gel, which is the treatment for acne vulgaris, which is a 1 milligram over gram adapalene, which is a first-to-market generic as well. And then we are also the sole suppliers of the Eastern range. So Eastern is made in Spain. They are actually market leaders in the Spanish market. And Glenmark South Africa has taken over the promotion of Eastern, and we will be the sole distributors of Eastern for the next 5 years. And those are the categories. So it's photo protection, which is your sunscreens, Urihaden range. So we are the only Urihaden range from a 10% concentration all the way to a 40% concentration. The Derma range, which contains a Ceristin shampoo for your psoriatic patients, a Nutritopic range, and then obviously Eastern Shootics, which would be for your aesthetic doctors. Thank you so much.
Thank you, Johan, for that concise and informative presentation, and we're excited to partner with Glenmark. I'm now going to thank you, and feel free to ask questions, but don't ask extremely difficult questions, please. Dr. Limba, I'm going to now do a brief introduction. Dr. Limba is a zealous and affable specialist dermatologist and consultant born in Mthatha. and she now resides in Gqeberha in the Eastern Cape, that's Port Elizabeth, previously known. Dr. Limba obtained an undergraduate medical degree at the University of Transkei. She fell in love with the skin's complexity and maintaining its beauty, and therefore pursued to do a postgraduate degree at the South African College of Medicine, the School of Dermatology, thus completing a dermatology training at the University of Witwatersrand in Gauteng, and a Master's of Medicine in Dermatology concurrently. After serving as an assistant lecturer in a senior year at WITS, she then extended her skills and services at the Tertiary and Quaternary Institution of Walter Sisulu University in East London. She later then opened a private practice in Gqeberha, and she's trading as Unique Skin, where she is the executive director. She aspires to be the first Black female MOHS surgeon in South Africa, working with indefatigable, let me leave that word out, enthusiasm to create awareness in dermatological conditions. With her expertise in managing clinical and aesthetic dermatological problems, she is active in programs directly linked to skin awareness, including participating in several radio programs that help educate people about skin-related matters, skin cancer, climate changes, and skin and the skin. Outside of work, she values spending her time with her children and her husband. Thanks very much, Dr. Limba. And now hand over to you. You may share your screen. Sorry about the trip over that word. Dr. Limba, do I need to unmute you? I think so. There we go. You may now start.
Thank you. Good evening, everybody. I'd like to thank Dr. Gqeberha and the sponsors, Glenmark, John, for giving me this opportunity. And I'd also like to thank the participants for giving off their time to basically engage and get an appetite through the speciality of dermatology, particularly the common cutaneous conditions that we encounter or that may be encountered in your GP practices. I'd like to start off to say that John had made mention, and also Dr. Gqeberha, that we are at a very times of challenges with the pandemic, but I'm also just grateful that we're able to engage and continue to engage as colleagues in platforms such as virtual meetings. Thank you for the opportunity. I'll now start my presentation. This is a slide which just reflects a very common skin conditions in GP practice. And the most highlighted in the top 20 are the inflammatory skin conditions, which include contact dermatitis. And as part of your top 30, we have the infective type of skin conditions, which mainly include viral infections, which then present as viral warts, and highlighting other common skin conditions, which are part of the infective or infections umbrella term, is superficial skin infections, which are commonly termed cellulitis. It further then highlights a variant of other skin conditions, which I mainly see in my practice, which include inflammatory conditions such as acne vulgaris, and also particularly with our population where we have fair-skinned individuals, in the top 100 common skin conditions that you might encounter in your practices are precancerous lesions, which are namely termed actinic keratosis. This slide just gives us umbrella terms that then categorizes these skin conditions according to their presentations. When we reflect to papillosquamous, it's a clinical term that we commonly use when describing the lesions in dermatology, where we have primarily papules and squame, meaning a scaly type of a lesion. And in this slide highlights the common ones that we encounter in our GP practices, including, as I've mentioned, acne vulgaris, dermatoses such as eczema, and eczema occurs in different forms or distributions in your body, hence given different terms and terminology. But as much as we see eczema, the common type that we see, and I also see in my practice as a referral, is a type of eczema that is associated with allergy or a genetic component that predisposes you to hypersensitivity of the skin, known as atopic dermatitis. Rarely I do have patients who are referred to me with psoriasis, but it's one of those skin conditions that presents with papules and a scale that might have an overlap in some time of its involution, and it can look like an eczema, but we will have images to appreciate the differences as we proceed with the presentation. Another common skin type of dermatosis is a dermatosis that presents with very fine scaling and very patchy, and it looks like petal leaves on the body, predominantly on the trunk, and it's referred to as Psoriasis rosea. As we go through our slide, we can see a respective list of infective causes, particularly superficial fungal infections, parasitic infections such as scabies, and most commonly as well, mechanical dermatoses such as corns, which are as a result as pressure or continuous pressure on the skins, particularly on the glabella areas, or we can refer to them as the hand and feet areas. And we do, I think less than one third of the presenting or referred cases from the GPs, supporting GPs at Gqeberha are neoplasms. And the neoplasms, when confirmed, it's either basal cell carcinomas, which are mainly superficial and localized to the skin, or superficial or sarcoma, squamous cell sarcomas are the next type of neoplasm that I usually see and is referred to my practice. And we have a basket of conditions that are randomly also referred to the practice, also less than one third. However, patients come in very distressed and in need of treatment. We will appreciate the type of scars that we are able to see commonly in practice. Hypertrophic scars, particularly in the earlobe region, and solar keratoses, which are precancerous lesions, seborrheic warts, or also referred to as seborrheic keratoses, which are benign lesions, particularly at a more mature age and a more mature type of a skin, where patients are really referred to my practice with very much concerns of whether the lesions are cancerous or non-cancerous. And another very common, however, I do have a small population of referrals of this condition, because patients who are mainly affected are the population with darker skins, and most of them are usually, particularly if they're more acquainted and learned with skin cancers, want to be reassured with this condition known as dermatosis papulosa nigra. It's basically, in simple terms, it's just warts that are gather up and are more focused on the face distribution and trunk distribution. And they look like warts, and some of them look like moles. As I've made mention, it's an overview of the common skin conditions, and we'll get to appreciate the primary lesions of the conditions that I've made mention in our previous slide, and also who does it affect primarily and how does it occur. And we also get to go over the overview of the treatment goals, guidelines, and when to refer. Before I move on to my next slide, I'd like to make mention that in terms of treatment goals, a very good guideline, particularly at your practice as a general physician, we've got a very good book known as the South African Medical Formulary, where we're able to pick up or able to have guidelines on the dose related to pediatrics, our geriatrics, and our ordinary population of age. When we touch on eczema, eczema, as I've mentioned, it's an inflammatory category type of dermatosis that you find in dermatology or see commonly in dermatology. But one needs to be cognizant of the fact that we have a genetic component of eczema, where we can have the type of eczema that is expressed, particularly at a younger age of 3 months, as a papulosquamous. We present with papules and a scaly rash, and a very, very typical distribution of the neck, face, the anterior popliteal fossa, and the upper arms, lower arms, the flexural areas particularly. But as I've said, you need to also be cognizant of when you're taking history of these patients on when the clinical presentation manifests. You might have exogenous triggers of the eczema, and these exogenous agents are irritants, or they could cause irritation of the skin or an allergic type of response of the skin. And particularly with our patients who are in the geriatric age of distribution, or in our population where there are in a lot of polypharmacy, which includes antihypertensives, antidiabetics. They will present with a later stage type of an eczema. And when you extract from the history, they do not have any prior history of having an eczema. So this type of eczema is categorized as a photodermatitis, where you have a long-term ingestion of these antihypertensive, hypoglycemic agents that accumulatively cause a photosensitivity reaction or photosensitivity response to the ultraviolet light. And I would like to highlight this point, particularly at your practices where a patient does not have a prior history of eczema, is in polypharmacy, including the agents that I've highlighted, antihypoglycemics, antihypertensives, and presents with an eczema type of reaction, particularly on the photo-distributed areas, which will be your face, the upper trunk, or your V-neck of the area. The endogenous type of eczema is the atopic, which is genetically, you are genetically predisposed, seborrheic dermatitis, and the others listed as respectively on the slide. In this image, we're able to basically appreciate the papules. If I had a pointer, I would use it, Dr. Gqeberha. However, The device I'm using, I don't have a pointer to use, but the erythematous, or rather red swelling, or areas where you have redness and swelling, elevation of the skin, we refer to those areas as papules. And you've got a scaly area where there's elevation of the skin or disformation of the skin. We refer to that primary lesion as a squame, hence the term papulosquamous. So with the involution of the skin condition or the dermatosis, in this case, acute eczema, we do have a presentation of another form of a primary lesion, which is vesicles. So vesicles are fluid-filled, elevated, dome-shaped lesions. And on the upper right, we can appreciate vesicles in this image. With the progression and involution of the disease, we can also have rupturing, or because of induced pressure or scratching on the skin, we can have involution of the skin condition where it presents with exudation or fluid. And when the fluid dries up, it becomes crusted. One needs to bear in mind in practice, some patients do present when the evolution of the process of the dermatosis is at this stage. And one salient point I would like to make mention is that you must always have a high index of suspicion that there might be secondary infection. So treatment, in terms of our treatment goals, would focus on treating a highly possible overcolonization of infection because of the presentation of exudation and crusting. And after we've cleared the infection, we can then commence with the focused treatment goal of anti-inflammatory products, which I will highlight, which include steroids and non-steroidal products or agents that we use to reduce the inflammation of eczema. This is also another picture where the vesicles are more pronounced. And this is a type of eczema where the distribution is predominantly on the hands. And we need to also bear in mind that occupational type of dermatitis can present with this type of picture where the patient comes in your rooms and has all of a sudden blisters which have erupted on the hands. So it's an involutory stage where one of the primary lesions can just be vesicles. This is an image where we were able to appreciate the crusting. And this is where I had highlighted that when a patient presents with this picture already, we must just bear in mind that there is a high index or high probability of a secondary infection at this stage. We then treat them with topical antibiotics initially and or oral, depending on the severity and the affected area of the body, which most likely, if the area is localized in one single area, topicals, we could get away with topical antibiotic agents. And I know Glenmark has a special product which we commonly use as well as dermatologists to apply on these lesions. And if then the distribution is pretty much more than, or it presents more than 30 to 80%, it would warrant us to give the individual oral antibiotics, including penicillins, if not allergic, the tetracyclines, if allergic. This is another spectrum of the disease, which when a patient then presents to you after a long journey of having had persistent dermatitis of the skin, they will present with thickening of the skin. And we refer to this as lichenification, where the lesions are more dry and the skin lines are more accentuated, and it has a leathery appearance. And it's also exaggerated by persistent acute phase, which has not been alleviated or treated, and also exaggerated by chronic scratching. This is another image where we were able to appreciate the exaggerated markings of the skin, thickening of the skin in a different skin type. This picture we often see in individuals who are more, have the contact type of eczema, particularly occupational type of eczema, where we have allergens or irritants, which are persistently are in contact with the individual. For example, where I work, I do have patients who present to me who are working at the hospital setting and are in contact with a lot of, particularly our soaps and our sterilizing agents, and the body accumulatively has a response to these agents, and we refer to it as contact or rather irritant dermatitis, which can present particularly on the hands with fissuring, which is opening or breaching the skin, where you see this deep furrowing, and also scaliness as well. I've made mention that atopic is a genetic type of eczema, presents about 10 to 20% of the population, and it often presents at a younger age, where infants, they manifest with primary lesions at the age of 3 months. There is also a very strong family history when you prompt or you dig into the history of the guardians of the child. A lot of them have a history of sinusitis or allergic rhinoconjunctivitis, and we refer to that trend as atopy. And you are able to, without doing further tests, have a high index of suspicion of this type of eczema, which is known as atopic eczema. And the typical distribution of atopic eczema is basically the facial area in the infants, the scalp, the cheek areas, and compared to the adults, it's usually the non-flexural areas. It's the opposite anatomical sites, which is the elbows and the knees, with the younger individuals, such as infants and young children. When then, with the developmental stages or evolution of the skin condition, if it is not well controlled, you can present with it, about 15 to 20% can present with persistent atopic presentation on the typical sites as an adult, which includes your periorbital area, your upper trunk or V-neck of the area, and your flexural areas, which you appreciate more in this image on your upper arms and your lower arms. Okay, I've gone through this slide. It's just appreciating on a more live image, the crusting around the face, the cheeks. And this is also a different skin type, where it might present with less erythematous flares, but rather thickening of the skin. I have gone through this just in summary. The distribution is different from infancy, and that it involves various anatomical parts in infants versus the adults. This is another image where we are able to appreciate the crusting, the involutory stage of the disease, and a few papules as well. Okay. Now, the sequelae of the condition of an eczema, it could be any eczema, but commonly atopic eczema, because the persistency is more appreciated compared to any forms of other eczemas. The complications of the sequelae are is over-colonization. We know that the skin is unable to basically protect itself from exogenous agents or irritants. And the skin is also unable to maintain moisture. And then it is predisposed to dryness. So dryness of the skin then prompts itch, or rather an itch. So persistent scratching because you're itchy predisposes you to more, opportunistic infections, including herpes, including bacterial infections such as staph infections, and other viral opportunistic infections that include molluscum, or the poxvirus that presents as umbilicated papules on the skin, and other complications, particularly with children which are not, where the skin condition is not controlled well enough. But it causes irritation and stunted growth. So the stunted growth is basically as a result of a child who's very unhappy, not being fed very well. And it is very important to basically control the skin condition and alleviate and improve the quality of life, so that indirectly we were able to have a child who's happy and has a very good growth pattern. I did mention initially that we do have a very good guideline for doses. So in my presentation, I will give umbrella terminology of our treatment goals or treatment focus. The first thing is to basically reassure the patient, encourage the patient. I do believe as a specialist that as part of our treatment goals is to achieve compliance. And I believe that when a patient is able to understand the process or the progression of their skin condition or any other pathology in their body, it maintains and enhances compliance. So having to explain to the patient what the etiology or the main primary cause is of a skin condition is one of my advocacies, to reassure the patient and encourage the patient as well. With these kind of skin conditions, particularly with the contact type of dermatitis, having to advocate for avoidance of irritants. With atopic dermatitis, particularly avoidance of heat, and to avoid any materials, particularly wool or cotton, wool materials rather, not cotton, wool materials that will retain heat, which will have a rebound effect of causing flare-ups. The role of antihistamines, and the common ones which we usually, particularly at a general practitioner's level or practice, we usually use the antihistamines that include allergics and non-sedative antihistamines such as cetirizine. The role of antihistamines is very indirect in eczema, except if it's a type of eczema where you have got a contact or an allergic exogenous or endogenous component or primary trigger. But in atopy, most of the time we use it as a just to alleviate the anxiety or the urge to want to scratch. But with contact dermatitis, there is a role, because the histamine release is then managed accordingly. Another group of agents that we use commonly, and I would advise that you have to be cognizant whether there is a superimposed infection on the presenting lesion or not, is topical steroids. A lot of patients who are referred to me have been treated, but particularly with a focus on topical steroid, and not bearing in mind that the lesions might have had secondary infection, and steroids do exaggerate secondary infections on lesions which have been chronically scratched and infection has been introduced. Another treatment focus is emollients, as I made mention that the skin is unable to maintain moisture. So emollients, we've got different vehicles of emollients, which start from fluids such as oils, and the most recommended oil or type of oil that we use, which is very friendly, is liquid paraffin, or an agent which includes liquid paraffin or glycerin agent within it. Our emollients can also vary, as I've said, in vehicles or composition, to more soft paraffins, which are much more thicker, to water-based or aqua type of emollients, which are more water-based and are much more used or commonly used. So we've got a variety of patients who then respond very well to majority the water-based type of emollients that we prescribe to them. But we do have a small population of patients where if we then prescribe water-based, they apply the water-based emollients, then you find that within the next 2 to 3 hours, they have to reapply the emollient. So that type of population, we advocate mainly for soft paraffins or Vaseline type of emollients, where the moisture is more retained at longer periods. Monitoring of these patients, this slide just highlights the recommendation and the use of topical steroids. Monitoring the patients who are affected by eczema, particularly atopic type of eczema, it becomes very tedious and cumbersome at times. But like I said, it's very important to advocate for reassurance and understanding of the skin condition, that we're targeting certain pointers of the skin condition. For example, the dryness. We need to maintain the dryness, or we need to alleviate the dryness, which if it is not controlled, we can also exacerbate the itch component, which is known as pruritus. The pruritus is not only as a result of the dry skin, it's also as a result of inflammatory agents or products which are released in the skin, which cause the redness and the swelling. So we also need to then advise the use of topical steroids. Depending on the severity, we can also opt for oral steroids. And we do have agents such as non-steroidal agents that we can also use on these individuals. I think I've spent a lot of time on atopic eczema. But the other types of eczema, which include seborrheic type of eczema, they relatively vary because of the distribution of the eczema, particularly in the infantile type of eczema. A mother will come in, bring in a child with a red neck, which has been persistently red and looks very angry and irritated. And it also involves the folds or the hair-bearing areas, which is your scalp, and we refer to that as a cradle cap, and the axilla and the groin area or the nappy area. Mothers who usually, or guardians who usually bring patients who are affected by this type of eczema, the children are often quite very less irritated compared to children who have atopic eczema. They're much more calm in relation to the type of presentation. And the eczema can be itchy, but less of a presentation with this type of eczema. This is a very thickened type of scale where if a patient then presents to you, particularly in infancy with a cradle cap, I would advise that we do not advocate for shaving the scalp, but rather softening the scale. And we use a product or an emollient product such as liquid paraffin. You could use also glycerine, and you could also use coconut oil. Those all have been very friendly to not causing irritation or basically causing exaggeration or worsening of the rash itself. So what that type of emollient does, it lifts the scale up, the very thick scale up. And as the scale lifts, you will have discomation or easy discomation of this thick scale. Then if there are any features suggestive of a secondary infection, like a crusty exudative lesion underneath the scale, I would advise that we use a topical antibiotic for a period of 5 to 7 days prior the use of anti-inflammatory topical agents. And I know that Glenmark has got a very wonderful product that I've been using since I was training, particularly for your under fives, which is a flu and sinolone type of moderately strong steroid. And it is very safe to use. And because of the distribution in the scalp, I usually prescribed quite a lot of the gel formulation. So the strength is one of the salient points of Sinula gel, known with an active ingredient of fluocinolone, and also the strength, the vehicle. It's got multiple vehicles, including the emollient, as John mentioned earlier on, but particularly in the scalp, I would advise treatment focus of the gel formulation. And also the frequency. After you've lifted the scale, application which would be recommended is twice a day, and it's very safe to use for your under twos. This is another image in a different skin type. When you see a picture like this, particularly on an adult, always have a treatment focus of treatment, which will include your antiseptic, antibiotic focus first to clean the overcolonization of secondary bacterial infection, then the use of topical anti-inflammatory agents such as steroids. This is another type of skin dermatosis, but I rarely see as a referral to my practice. But I do know that there is an overlap between this skin condition and eczema. Now, psoriasis versus eczema is the abnormal multiplication of the skin layer, which is the top layer of the skin, which rapidly multiplies and forms this thick erythematous, scaly, gray scale type of a lesion. It occurs in different variants, which I'm not going to elaborate on, but I think we just need to appreciate the difference in terms of the primary lesion of the psoriasis versus eczema. It's characterized, particularly the common type, which is plaque type of psoriasis, characterized by a well-defined plaque, which is usually distributed, it can be distributed on the trunk, distributed on the face, on the scalp, hair-bearing areas, and but the giveaway versus eczema is a well-defined plaque, erythematous background with a scaly, silvery papillosquamous lesion. There's a common test that we usually do, which I'd like to share as well. And we call it an odds put sign. When you want to have a clinical differentiation between eczema and psoriasis, you take a little wooden spatula and you scrape off the scale or the silvery scale, and you present with a pinpoint type of bleeding just underneath the scale. And it's a clinical sign that gives us a high index of suspicion that this could be clinically psoriasis versus eczema. It is a genetically predisposed dermatosis, and other predisposing or precipitating factors include trauma, infections, hormonal influences, drugs, and smoking. So in basically taking your history, these are the types of precipitating factors you'd want to elicit and basically have background of in focus of your diagnosis of psoriasis. Like I mentioned, it can present in various variants, and we have the typical sites and the classical presentation of a plaque type of psoriasis, but these are the areas that are clinically can present with the lesions as well, including your scalp, nails, and the other variants, which are erythrodermic, which is basically 80% of your body has been, the lesions have disseminated to 80%, involving 80% of your body, and you have a weeping type of lesion on the body distribution, and red, and the patients usually present with fever, and chills, because the skin is severely affected and is unable to, one of its function is to maintain thermoregulation, is unable to actually execute that function of thermoregulation. So erythroderma is another type of clinical pattern of psoriasis. But I think for more definitive diagnostic, tools at your practices, the classical clinical type is the one you will be able to pick up. And if in doubt, this is the type of psoriasis where we usually advocate for referral, and referral so that a skin punch biopsy can have a confirmation, and further investigations as well. Okay, these are the sites where the common type of psoriasis attacks or is manifested in the body. I'm not going to spend more time. So with psoriasis, the treatment focus is to basically improve the quality of life. We've got topical agents that are available, and the topical agents that we also have available from Glenmark, which I do love dearly, is keratolytics. So what do keratolytics do? They basically reduce the thickness. They have an exfoliative effect on the abnormal thickness of the skin. And the product that we have, wonderful product that we have from Glenmark, is a Uridin. You have a 10% formulation up to a 40% formulation of this product, where you are able to use and prescribe for your patient as a keratolytic, which will then reduce the thickness of the scale itself. We are then able to also prescribe emollients, which will alleviate the dryness of the skin. And products, we've also got another product, is a lino product, which has a tar formulation, which has an anti-inflammatory effect that also reduces the thickness of the scar. I beg your pardon, the thickness of the lesion. And it also has an antimitotic effect. Antimitotic effect, it reduces the multiplication or rapid multiplication of the scale itself. Another keratolytic that we can use besides the urea or Uridin that we have readily available is a salicylic type of acid. But I would recommend that this be prescribed by a physician who is more familiar with the product, because particularly if you then prescribe it for younger individuals, the level of toxicity might be a red flag. And when using in adults, the titrations are very important to be spot on with. So it's another type of keratolytic where I would advise that a physician or a clinician that is familiar with the product would use. I usually use, particularly with the thick, scaly lesions that present with psoriasis, I usually use a 40% formulation or compound. And I must make mention that our pharmacies in Gqeberha, compared to the other areas that I've worked in, are not really, friendly or rather supportive in terms of, mixing compounds and having compounds readily available for your clients. But we do have a very wonderful keratolytic product, which is already ready-made in a form of urea. Topical steroids. I think the most important treatment focus for topical steroids is a topical steroid of a moderate to a potent strength, particularly the betamethasone, the Dovate, and particularly the one with an analog, vitamin D analog, which has been quite proven to have efficacy in terms of involuting or treating the actual thickness and thickness of the psoriatic plaque itself. Okay. Another inflammatory condition. I don't know whether Dr. Govender, we've got questions based on our inflammatory dermatosis, psoriasis, seborrheic dermatitis, and atopic, particularly, before I move on to acne, or should I just continue with the presentation?
I think you should continue with the presentation, Dr. Limba. How much longer have you got?
I think I've got about 30 more minutes.
Right, it is coming down to 8:30. So if you can just be cognizant of the time. Please go ahead.
This is a skin condition, inflammatory dermatosis, papulosquamous, that is known as acne. More than 2/3 of my clients, particularly the adolescents and young adults, present with this. And at your primary level as well, or at your practices, I've had a lot of referral of patients who present with this, with these lesions. And the primary lesions of acne are papules, comedones. Comedones are blackheads and whiteheads, and we can appreciate on the right side of the image where we have comedones such as blackheads. I think the main focus when patients present to you with acne is to be cognizant of the severity of acne. We do have acne presenting in its mild form, where we are able to manage and control and even cure the severity at its mild form by the use of topical retinoids. And we do have adapalene as an active ingredient, which is readily available for use. And we can also combine, because of the pathogenesis of acne, combine it with a peroxide, which is also readily available from the pharmacy, which will then target the bacteria, or has an antibacterial effect on the pathogenesis of acne. As the disease evolves in severity to a more moderate form and severe form, the patients, in terms of using or the use of topical agents, we have a small percentage of them responding, and the topical agents will then reach a plateau. And this will then be your red flag, or the point where I would advocate for referral and initiation of oral treatments. But the oral treatments depend also in severity, because we do have a group of oral treatments which include oral antibiotics, which are tetracyclines, and the oral vitamin A derivatives, particularly the isotretinoin, is much more modern and much more trending in terms of prescribing, and has less side effects, particularly if you have female individuals who have intentions of having a family. The bioavailability is then lost within 3 to 4 weeks, and the female individual is able to conceive. Another important point with acne, you will then treat the acne on a given time period, but it's also important in terms of maintenance. Maintenance of acne is so important that you do not want to have your patient coming and saying that the treatment is not working. What is important is to focus also on what they use as cleansers and what they use as moisturizers, because the moisturizer vehicles, which are ointments and oil-based, they tend to exaggerate or cause flare-up of acne because of the occlusive mechanism on the open or the pores or on the orifices of the follicles themselves. The herpes infections are also very common infections, but these infections are easy to identify because the patients present to you with a very painful lesion, vesicle, or fluid-filled lesion, and most commonly it could be present on the mouth region or periorbital region or perinasal region. Chickenpox is another variant of a varicella or herpes infections that can present in infancy, but we also have patients who are immunocompromised that can present with this type of disseminated type of virus infection. This is the dermatomal type, where you have also crusting and features of secondary infection. The advocacy or focus of treatment would be to treat with an antibiotic, particularly oral and topical, and antiseptic washes as well. The slide then highlights the group of antivirals you can use, acyclovir, and you can also use, depending on the dissemination, particularly with our immunocompromised patient, you can also use valsarcovir, which is not necessarily readily available. Okay. I made mention of molluscum caused by poxvirus. See this kind of lesions commonly in younger individual. It's known as molluscum contagiosum, meaning that it is a contagious skin type of manifestation. If you scratch the lesion and you scratch another non-infected or non-contaminated area, you will have an eruption of the papules. And the characteristic feature of these papules is usually umbilicated papules, dome-shaped, and there can be anywhere and everywhere in your body. But commonly in infants, the face is a common area of presentation. Treatment choice. I will make mention, I'm just going to skip these slides quickly. Treatment choice of these type of lesions is symptomatic, really. There is no direct treatment for viral skin infections. And we use a lot of irritants in the form of immunosuppressive agents such as imiquimod, 5-fluorouracil, and there are home remedies which you can advise to your patients, but if only they present with one lesion, is to nick the lesion and then sterilize the surface area of that region where you've nicked the lesion. Should then the material which is extruded from the lesion touches or gets in contact with a surface which is not contaminated, there will be a manifestation of the lesion. With the viral warts, which are commonly caused by human papillomaviruses, you also have different genotypes. And in infancy, you would have, particularly on the region of your hands and the genitals, And when you see a child with genital viral warts, particularly HPV related, you should always have at the back of your mind to inquire for any form of sexual assault and be cognizant of that. Other than that, it's commonly because of the guardian or the parent who's handling the child who has had a previous lesion that they're able to then contaminate a non-contaminated skin, and then the child presents with multiple lesions like this. And also, you should also check for immunosuppressive status of the individual, particularly if you've got an older individual who presents with multiple lesions, HPV related in the genitals. Like I said, a lot of infective skin dermatosis can present to you, and you might have an overlap of primary lesions. And we have a fungal infection that looks like an eczema, but characteristically, a superficial fungal infection presents with an annular type of a lesion with scaly, and the edges are usually very active with papules that coalesce or come together to form this kind of classical picture. And if you have a child who then presents to you, or an adult, the bedside test, which is easier to do, is to do a skin scrape and send it for KOH at the lab to confirm whether microscopically there is a fungus. We do know that the cultures take longer, but just to differentiate between an eczema and a fungal infection, it's a basic bedside test that you can do at your rooms, which will give you a focused treatment of use of steroid versus use of antifungals. The therapy, focus therapy of antifungals includes topical, particularly for localized lesions, and systemic antifungals, particularly for extensive type of lesions. The role of referral is when your patient or your client does not respond, having done a bedside test and this persistency of the lesions. You would advise treatment focus to extend beyond the presentation of the lesion. In other words, you'd give treatment focus treating a superficial skin fungal infection localized with an antifungal topical cream, particularly at the elamines or the azoles group of antifungals. The lesion will then disappear, but it's also advised that two weeks then after, you continue with the topical antifungal on that lesion, even if clinically with your naked eye it's not observed, because the recurrency rate is then minimized. Okay. I think that is an overview of the common skin lesions that I was able to touch on, and those that I am given the opportunity to appreciate as referrals in my practice. However, I do have useful websites where our clinicians are able to appreciate more in terms of the treatment focus of any other forms of skin conditions that they see in their practices, and most helpful and user-friendly sites that I can recommend include the ones mentioned, and particularly the DermsNet, which has very, very obvious pictures and images that can be helpful at your practices. Thank you very much. This will be the end of my talk. I do apologize for overlapping 10 minutes into my given time slots. Dr. Gqeberha, over to you if you've got any questions.
Dr. Limba, thanks very much for a most interesting, comprehensive, and highly informative talk on skin conditions in GP practice, and most helpful. I'm not sure if anybody is on two devices. There's an echo. Dr. Limba, you can switch on your video. We are now going to enable attendees to unmute and ask their questions. I have posted the register in the chat section. Please complete the register to get your CPD points. Okay, so you will now be able to unmute yourself if you want to ask a question. I'm going to also check the chat section to see if there are any questions. Dr. Limba, in terms of emollients, what product names would you advise?
Thank you, Dr. Governor. In terms of emollients, I think what's important really is the formulation. There are a lot of products that we do advocate for, and I know that Glenmark has got a very wonderful nootropic product they have, particularly for infancy, which is more of a soft paraffin, glycerine, aqua based type of a combination of emollient, which retains moisture in a very satisfactory manner. And you also have to look at individualize your patient, particularly with infancy. They've got a small body surface area, but then they release a lot of heat. So the formulations which are more Vaseline based tend to exaggerate and retain more heat, which has a rebound effect on them. So the more aqua, water-based type of formulation emollients tend to work better in alleviating or maintaining moisture. But the only downfall is that you have to apply it more frequently compared to the more Vaseline-based type of emollient. And as I've mentioned, Glenmark has got a very wonderful range for atopy as an emollient. And we also have other products which have very, very good formulations that maintain moisture as well.
Dr. Modi, I'm sure you've got a question or two while he's preparing himself to ask the question. Dr. Limba, could you speak to us about the use of Roaccutane and the equivalents and the age groups for usage and side effects and what we need to be aware of?
Thank you for the question. Roaccutane, which has an active ingredient, isotretinoin.
Correct.
In terms of the current formulation, we've got a lot of companies to make mention that do have this active ingredient. However, isotretinoin as an active ingredient is a treatment of choice. And we do have guidelines in terms of prescription. We can then look at giving our patients according to their body weight. And it's between 120 milligrams to 150 milligrams as an accumulative dose. And when we're looking at our age, we look at adolescents from the age, we basically, I usually individualize my patients because in literature, you might have guidelines that give you from the age of 14 that you can initiate this treatment. However, you have to individualize your patient in terms of compliance and having to complete the treatment itself. So I tend, as a specialist dermatologist, to look at overall, at a patient and starting at an individual from the age of 16. We also then look at the sex of the patient. Particularly with females, we have to consider the fact that Are they fertile? Are they planning on having a family? Because of one of the common side effects of isotretinoin, which is teratogenicity. We do a baseline pregnancy test to avoid giving a patient who's already pregnant. Other common features or frequent side effects of isotretinoin include dryness. So dryness, particularly the mucosa. The mucosa type of skin you find on the lips, the nose, and the eyes. So in prescribing this treatment, you have to make the patient aware of the frequent side effect and how to alleviate or mitigate the side effects of dry lips. We give a very good moisturizer, and also alleviate and moisturize the nasal mucosa by giving Salix, which is a normal saline over the counter, and also spursid tears or artificial tears, which you get per prescription to moisturize and alleviate the dryness of the eyes. But then you do have patients who then complain of dryness in other areas, particularly if the patients are sexually active, and you would advise accordingly in terms of lubricants or alleviation dryness in those areas. We go to the skin itself. The aim is to cause dryness, dryness on the focused area, which is the acne site, where there is oversecretion of sebum. So, but other individuals tend to then experience dryness elsewhere. So the best way to alleviate dryness elsewhere, which is the rest of the skin, is to just use a very good moisturizer in a form of, it could be an aqua-based type of formulation to a more Vaseline-based type of formulation. But I think the patients that I've had in practice and experience, the aqua-based type of formulations, they do just in terms of mitigating the dryness of the skin. Another side effect, which is often experienced in high doses, particularly if you're prescribing 40 milligrams and above, besides severe dryness, is basically patients who are predisposed to mood disorders, particularly depression, suicidal ideations. You need to take that into consideration and, convey that type of side effect, particularly if a patient has had a background of such traits or manifestations in the past. And also back pain or bone pain rather is another side effect that's commonly expressed, particularly in higher doses. So how do we mitigate that? It's titration, downward titrations of the drug itself into the minimum accumulative doses is 120. And another side effect, but rarely you have this side effect, but you do baseline bloods for it, is hepatotoxicity, which I've only experienced, although literature says that we should be cognizant of. I've experienced that side effect mainly in patients who have been on polypharmacy, and it has been 1 or 2 or 3 patients rather in my training where they'd had side effects with liver toxicity. Then we actually mitigate the side effect by stopping the drug and giving a free period or a acetretin free period of about 4 weeks. And we can then restart or re-challenge the patient with another baseline liver function test to then see whether the toxicity to the liver has been sustained or it's persistent. If it is persistent, we just stop the treatment. Another side effect is lipogram. I beg your pardon. It's dyslipidemia, but mainly it's baseline dyslipidemia, which has been established before treatment, and you just monitor it. And it depends on the titration of the cholesterol levels. Your 4, and if it's relatively just above 4 and it's in the 5s, you could safely, cautiously give and then monitor after 3 months then after. But it all depends in terms of prescribing, individualizing your patient, and advocating or having to tell the patient about the most common side effects to look for. And it's also important to have a consent sign when you're initiating this treatment. Should anything happen highlighting any of those side effects, you are safely also protected as a clinician. Thank you.
Thank you for that comprehensive and most helpful response, Dr. Limba. I'm picking up some questions from the chat section. And the question from Dr. Isaac is, kindly comment on the use of cotrimoxazole in acne. Dr. Limba,
Thank you for that question.
Dr. Limba, would you stop sharing your screen? And perhaps switch on your video so we can see you. There we go. Yeah, why deprive us of this picture? Such a lovely picture. Okay, so your comment on use of Bactrim cotrimoxazole in acne.
When we approach, we have a treatment focus of acne. We always consider the severity of acne. And by the time you have considered the use of antibacterials, which is our first line oral therapy, we do consider antibiotic groups, including cotrimoxazole. However, cotrimoxazole versus tetracyclines, it's the bioavailability and the efficacy and the curative rate, which varies. So cotrimoxazole versus the tetracycline groups, we have to consider those three main salient points that if we then consider using our tetracycline groups, there's more efficacy and the curative rate is higher. And also in terms of bioavailability on the skin, there's more bioavailability with tetracyclines. But as I've mentioned, that you also look at the severity of the acne. The role of cotrimoxazole is advocated particularly with the pustular type of acne and maybe the milder form of acne, but with the pustular type where the Bactrim or the cotrimoxazole will have an anti-inflammatory effect on those pustules. Then moving on to your nodular cystic acne, then it will give us another group or another type of oral agents to consider, particularly isotretinoin or vitamin A derivatives. Thank you.
Thank you, Dr. Limba. And then from Dr. Modi, the question is, when do we use aqueous cream with urea?
Aqueous cream is under emollients. Urea in combination with aqueous cream is it has got an emollient and an antipyretic effect. So if you then present with a patient or a client who then complains of scaly type of dermatosis or very dry skin rather, and an associated symptom or sign of itchiness, I would then consider giving a combination of an aqua emollient with a urea emollient. Just remember, in children, you could also consider treatment focus of just exclusively use of emollients if they present with a very dry skin and a very mild inflammatory rash of eczema. It works just as well to alleviate particularly the pruritus or the itch and to maintain the moisture. I hope I've answered that question.
Thank you, Dr. Limba. Just again to the attendees, we've posted the register link in the chat section. Please click on it and just complete it. It'll take you about a minute. The next question in the chat section from Dr. Modi. I think he's been Googling now to get some questions for you. I have to tease you, buddy. The role of Montecasts in atopic dermatitis.
Thank you for the question. It's been a lingering query throughout the clinicians and with us dermatologists. But with literature, the last literature review, which was shared with us as dermatologists, the role of Montecasts in atopic eczema has, in terms of presenting significance, has been very minimal. The main role, because we know that atopic eczema trends with atopy, which is allergic rhinoconjunctivitis and asthma. There has been a lot of use, particularly with asthma, with this active ingredient, and it has had a positive impact, but we have not had appreciation, a lot of appreciation in dermatology. So our last literature review, which was shared with us in 2000 and I think it was, 4 years ago, which was shared with us with the dermatologist who did a lot of research in Cape Town with regards to this agent, did not really have a significant impact in the use of atopy, particularly atopic eczema.
Thank you, Dr. Limba. And then the next question is, kindly advise on eczema around the eyes and eyelids, as steroids may not be used here.
Well, it depends on the severity. But having said that, we do have non-steroidal agents that we can use that can alleviate the itch, not only the itch, but the thickening and the darkened pigmentation around the eyes. And non-steroidal agents, which I commonly use, are calcineurin inhibitors, topical calcineurin inhibitors, particularly the cream formulation known as Elidel. But one needs to consider the severity as well. We do have a steroidal agent that we can use around the eyes, which is very friendly with minimal side effects, and you can get it over the counter. It's a formulation, it's in a cream formulation and or ointment formulation known as hydrocortisone. You've got different trade names from Biocort to Milocort. So in terms of use around the eyes, should then the rash evolve and then disappear, the use of steroidal creams around the eyes is then titrated downwards. You'd use it when there's an active rash rather than when there's no active rash. And then with the non-steroidal agents, particularly when it's an acute flare-up, a very fresh red rash, then I would advocate for non-steroidals. The chronic type, then I'd advocate for the very mild form of steroids, hydrocortisone. But with bearing in mind the side effects when using the treatment on a non-active lesion or a site where there's not an active lesion.
Dr. Limba, thank you. Is there any way of diluting steroid creams? And what would you suggest?
I'm a very big fan of diluted compounds, particularly if you are at a stage where you want to focus on maintenance. However, have pharmacists with the right and correct formulation to do that. The reason is that you might then mix a compound, it might not be the right quantity, right strength, or right efficacy. And on top of that, all the compounds that we mix actively do not have preservatives. So if a patient then keeps that compound for 4 weeks to 6 weeks, particularly on the 6th week, the effectiveness and the efficacy of that compound is as good as using 1% hydrocortisone.
Thank you.
Rather have a pharmacist who's readily available to make the product for you and dispense it to your clients.
Thank you, Dr. Limba. The next question from the Zoom chat is there still a role for the use of Selsun shampoo in the treatment of seborrheic dermatitis, as was often used in the past?
There are different schools of thoughts. Thank you for the question. There are different schools of thought where we have the old school, which we do appreciate the wisdom of the old school, where literature reflected that one of the triggers of seborrheic dermatitis is superficial or overcolonization of superficial fungal infection. And we do have the other school of thought where really there is no role of antifungals. I do advise, however, if you have a patient who presents with seborrheic dermatitis, to treat with anti-inflammatory products, particularly if it is not in the hair-bearing areas, which is your scalp, it is just as effective. If you then move to locatory areas or regions such as the scalp, and the eczema is persistent, it then justifies one to advocate for use of antifungals, which includes a Selsun shampoo, particularly if it's resistant and calcitrant. But then I would then advise that particular general clinician to refer for further management and assessment to determine whether is there a role for anti-inflammatory or antifungals. Thank you.
Thank you. This might be an overlap. The use of topical antifungals in seborrheic stroke cradle cap eczema.
Yeah, I did make mention that depending on the area, anti-inflammatory is the first choice of treatment, anti-inflammatory in the form of steroids. Make sure there's no secondary bacterial infection, which is presented by crusting, oozing. You treat that with topical antiseptics, prior anti-inflammatory agents. If you have then made use of anti-inflammatory agents and there's persistence of the dermatosis. Persistence means you've treated a rash for minimum 6 weeks and it looks as worse as it was 6 weeks ago. I do then consider use of antifungals or topical antifungals at that stage, but primarily it's anti-inflammatory products.
Thank you. Next question, and I think we get close to rounding up, even though you've managed to still capture the attention of close to 66 participants. So clearly very captivating. Besides hepatitis C virus, any other common infective precipitants of psoriasis?
Although it has not, thank you for the question. Do you mean precipitating factors in infective types or other?
Okay, so the question I'm reading is, besides hepatitis C virus, are there any other common infective precipitants, in other words, precipitating infections that can cause psoriasis?
Well, the infective types that I'm aware, it's more the viral component, not necessarily bacterial. With review to literature as well, as far as the literature that I've captured, particularly viral, not any other category of infections that I'm aware of.
Thank you. Are there any other questions? You may raise your hand. Dr. Limba, we've been at it since 7:30, although you haven't spoken for all of that time, spend time on introductions. It has been a phenomenal presentation on skin conditions. There are numerous positive comments in the chat section indicating how informative and excellent your presentation has been. Doctors from all over the country have attended this presentation, and thank you for so freely sharing your knowledge with general practitioners. It's been a great privilege for ECIPA Healthcare to partner with you and Glenmark. We thank you for your time and your expertise that has been shared. We also thank Glenmark for having confidence in our organization and for partnering with us. I would like to just hand over to Jan Walters to make any final closing remarks. And just a reminder to everybody that the register has been posted numerous times, and I'm doing it again. Dr. Limba, there's a question there about, are you happy to share your presentation?
IP, papaya, papa. I am comfortable.
But in any case,
I'm comfortable to share my presentation.
We have recorded this presentation, and we will be uploading it to YouTube, to ECIPA Healthcare's YouTube channel. And I think it'll be much nicer for the doctors to hear your voice and see your face than to just look at a PowerPoint presentation, because the full content of your presentation will be on there as well. But
Thank
since
you.
you've agreed to share it, do you mind if I email the presentation to the attendees?
No problem.
Thank you. Then there's one more question. Retrovirus as a precipitating factor of psoriasis?
Well, I think, thank you for the question. It's more of an indirect precipitant because you have your regulatory immune system being compromised, not particularly a direct impact. So even in literature, we do make mention of compromise with regards to emotional state. So if someone has been diagnosed HIV, there's an emotional component to it. There's also an immunological component, which does not necessarily directly have an effect on the manifestation of psoriasis, but we have had very rarely, particularly in my training, where we had a very atypical presentation of psoriasis in immunocompromised individuals, presenting with a reactive type of arthritis, psoriatic pustular type of presentation. So, but rarely. But the pathogenesis is not directly implicated with the virus itself, but more like the immune status or background of the individual holistically. And other opportunistic infection that precipitates the manifestation of the genetic component, if there is a genetic component in that individual.
Thank you. There's so many doctors from outside of Gqeberha posting positive comments. I'd just like to let them know there's no chance of Dr. Limba leaving Port Elizabeth to relocate anywhere else. We are holding on to her. Johan, I leave it to you to make the final remarks.
Dr. Gqeberha, yet again, thank you so much for arranging this and obviously partnering up with ECIPA. You know, it's such an honor for us as a company. We haven't had representation in the Eastern Cape for a lot of years, and we actually have 2 representatives currently in the Eastern Cape. So obviously we would appreciate the support. Dr. Limba, I really appreciate your time. The information is invaluable. And as Dr. Limba mentioned, obviously there's a lot of skin conditions, and Glenmark Dermatology has got a wide range of products that can help all of the general practitioners out there. So if you see visitation from a Glenmark representative, please allow them, please give them 2 or 3 minutes and hear what they've got to say. I thank you all so much.
Thank you, Johan. Thank you, colleagues. Thank you, Dr. Limba. Take care, everybody.
Thank
Stay
you.
safe. And Johan, we look forward to ongoing partnership with Glenmark. Dr. Limba?
Thank you, Dr. Governor. Thank you, colleagues. Have a good evening and stay safe. Take care. Thank you, Glenmark. John, thank you.
Bye.